If you're looking for French interpretation, please click the interpretation button on the bottom right of your screen, and you should be able to find French there for you to listen to. Just a little bit about Project ECHO Etiquette. ECHO is founded on love and respect. Please respond kindly to people rather than react if you disagree. It is everybody's responsibility to keep ECHO a safe space. Please test your equipment ahead of time, both audio and video, and introduce yourself before speaking if you are going to speak. Please avoid making too much noise, shuffling papers, cell phones, loud bags, etc. For questions during the Q&A session, please use the chat box at the bottom of your screen. We're going to be taking questions that way. Please mute your microphone when you're not speaking, which is on the left bottom corner of your screen. And if you are to speak, please remember again to unmute your button and speak close to the microphone. Position your webcam effectively to show your face if alone or to capture the whole group. Have a light source from the front so you avoid being backlit. And if you have any IT issues, please send a message to us through the chat email function. You can send it to SSAC Echo and we can help answer any of your questions. I'm now going to introduce our first presenter, Dr. Bantayehu Sileshi. He is an assistant professor of cardiothoracic anesthesiology and directs the Cardiothoracic Fellowship Program at Vanderbilt University Medical Center in Nashville, Tennessee, in the United States. Dr. Sileshi, originally from Ethiopia, is also highly involved in education capacity building programs for anesthesia providers in East Africa. Over to you, Dr. Ban.
Thank you very much. I'm actually just going to do a brief introduction of our speaker today. But before I do that, since we're kind of in the middle of the series, I thought I'd highlight the topics that we have already covered as you have access to these lectures via video. So we started our series with a talk from Dr. Massion on respiratory clinical symptoms and treatment. Next slide, please. Dr. Massion covered how to recognize the pathogenicity of COVID-19, how it presents, and some imaging modalities, how to diagnose it, and how to take care of it in the ICU. Next slide, please. That was followed by a presentation by Dr. Schlesinger and team, really honing down even further on ICU care and ventilation strategy for these patients. Next slide, please. And on their talk, they nicely summarized the presentation and the diagnosis of acute respiratory distress syndrome. They went over specific algorithms for COVID-19 respiratory support in the ICU, and a nice discussion on prone positioning in addition to anticoagulation protocol. Next slide, please. That was followed by a presentation by Dr. Banerjee and team on multi-system organ failure and sepsis. Next slide, please. And on their presentation a couple of days ago, they really went in systems-based fashion, covering different organ systems that are affected and how to manage them in the ICU. So I'm reviewing these topics for you. If any of these topics are of interest for you, please feel free to go to our website and view these videos, which are available and which are nicely done. Next slide, please. So today we're going to specifically focus on cardiovascular disease in the setting of COVID-19 infection, talking about the clinical features and the management. We are very fortunate to have Dr. Henry Okafor, who's the director of the Vanderbilt Meharry Cardiology, originally from Nigeria, and a good friend of ours. So with that, I'll turn it over to Henry.
Thank you, Brian. And thank you all for coming. Let's proceed. Next slide, please. Nothing to disclose here. Next. Today, our learning objectives will be to look at the spectrum of cardiovascular disease in COVID-19 and also review some of the clinical features as they are changing every day. We'll discuss the approach to
de la maladie cardiovasculaire.
Managing cardiovascular complications. And we'll also highlight some of the potential adaptations in low resource settings. Next slide. I'd like to lead off with
des cas, en fait.
Case presentations to give us an idea of some of these features we're going to be talking about. Next slide, please. I'll start off with a 55-year-old man with a history of hypertension and type 2 diabetes mellitus who had previously known heart failure with reduced ejection fraction and non-ischemic cardiomyopathy, left ventricular ejection fraction less than 20%. He presented with 1 week history of progressive dyspnea or mild exertion, which was not totally unusual in his condition, and then complicated by 3 days of exertional angina, which was entirely new. On presentation, he was hypertensive, but afebrile, and oxygenating at 96 to 98% on room air. He had positive bibasilar crackles, elevated jugular venous distension, S3 gallop, 2+ bilateral pitting edema, all consistent with acutely decompensated heart failure. Next slide, please. The workup revealed EKG with normal sinus rhythm and premature atrial contractions, left axis deviation, non-specific T-wave changes, elevated troponin of 1.07, pro-BNP was 22,000. He had cardiomegaly and pulmonary vascular congestion, and evidence of biventricular failure on 2D echo with left ventricular ejection fraction less than 20%. He had grade 3 diastolic dysfunction and small posterior pericardial effusion without any tamponade physiology. Next slide, please. On the left hand, you can see his EKG, as mentioned, especially in sinus rhythm with PACs. And on the right, you can see his chest X-ray showing significant cardiomegaly and mild pulmonary vascular congestion, but otherwise, nothing, no clear infiltrates. Next slide, please. This is the 4-chamber apical view of the echocardiogram and still images. On the left, you see you have the left ventricle and right left atrium, and you have the right ventricle. All the chambers look mildly enlarged, and you can see on the right that there is some tricuspid regurgitation and mild tricuspid regurgitation and trace mitral regurgitation which are present, which are mainly functional. Next slide, please. Patient was treated with intravenous diuresis and improved significantly until on the 3rd day when he spiked a temperature to 101.7 degrees Fahrenheit and became relatively hypoxic with increasing demand for oxygen supplementation. Septic workup was initiated and inflammatory markers were all elevated, including C-reactive protein, fibrinogen, ferritin, and D-dimer. He tested positive for COVID-19, which was done later, and needed needed to be treated with azithromycin only because his baseline QT was prolonged. So the infectious disease selected not to treat with hydroxychloroquine. His hypoxia improved and his fever resolved, and he was discharged on day 15. Next slide, please. The second case is a 68-year-old woman with also hypertension and type 2 diabetes who was already tested positive for COVID-19 10 days earlier, but presented subsequently with respiratory distress and immediately required mechanical ventilation. She seemed to be doing well until day 5 when she became acutely tachycardic and hypotensive and required vasopressors. Septic workup was initiated. She was echocardiogram was ordered. Next slide, please. And the 2D echo showed that she now has severely impaired LV systolic function with EF of 25 to 30%. She was not previously known to have any heart failure or cardiomyopathy. So she required inotropic support with low-dose dobutamine and hemodynamics stabilized over the next 24 to 48 hours. And a repeat 2D echocardiogram 7 days later showed almost normalized left ventricular systolic function with EF of 45 to 50%. Next slide, please. Talking a little bit about the epidemiology of this COVID-19, obviously started off in Wuhan and now a pandemic caused by SARS-CoV-2. We know there has been previous SARS-CoV-1 and MERS. It's primarily a respiratory disease with extensive interaction with the cardiovascular system, and as we know now, with most other organs too. You do have patients with cardiovascular disease are known to be at higher risk of getting this infection, and they have a worse outcome. Also, cardiovascular complications are relatively common in these patients. In some rates, it's as high as 20-30% of these patients get cardiovascular complications. And some of the current treatment are known to also cause cardiovascular complications such as arrhythmias. Next slide, please. In this study published in JAMA in the past month, showed that in those with cardiovascular disease and elevated troponin who have COVID-19, the mortality was the highest when compared to those without cardiovascular disease and normal troponin. So the graph, the line on the top is those with cardiovascular disease and elevated troponin, whereas the lowest or the best survivor were those with cardiovascular disease, without cardiovascular disease and normal troponin. In between, you notice that even in patients who have cardiovascular disease but had normal troponin, had a better survivor than those without cardiovascular disease who had elevated troponin, telling us that the elevation of troponin is a marker of poor prognosis in these patients with COVID-19. Next slide, please. We also, this study just confirms that cardiovascular disease is pretty common in COVID-19 patient. In the largest study from China, it showed that 10.5% of those patients had cardiovascular disease, while 7.3% had diabetes and 6.5% had hypertension. In some studies, a little bit reversed, but this is just telling us about the frequency of cardiovascular disease and or cardiovascular disease risk factors in patients with COVID-19. Next slide, please. Diverse cardiovascular diseases are seen. Patients can come with pre-existing cardiovascular disease, as in our first case, hypertension, heart failure, coronary artery disease, arrhythmias. But there are also SARS-CoV-2 related cardiovascular disease that is being observed. Heart failure will reduce ejection fraction, sometimes going into cardiogenic shock. Some are coming with acute MI, both STEMIs and non-STEMIs, that's ST elevation myocardial infarction and non-ST elevation myocardial infarction. also with a lot of mimickers in form of myocarditis showing up even on your EKGs. Thromboembolism is a rising concern, and arrhythmias, of course, and also treatment-related cardiotoxicity of some of the medications and complications of arrhythmias from this treatment is other things to pay attention to. Next slide, please. Next slide. Okay, so here we see the frequency of cardiac injury. This study actually was a little conservative. I mean, we can see that acute cardiac injury as defined by elevation in cardiac troponin was 7.2 overall, but as high as 22% in those patients in the critical care unit, which means the more severe the illness, the more the myocardial damage. Also, arrhythmia was as common as 44% in these patients with severe disease in the critical care unit. Next slide, please. A little bit on the pathogenesis. I know it's been discussed in previous presentation, but here we know that SARS-CoV-2 is a single-strand RNA virus, which enters the human cells mainly by binding to the H2 receptors, which are highly expressed in the lung alveolar cells and also on cardiac myocytes and vascular endothelium. This will lead to mild to moderate viral illness and can progress, as we have seen, to systemic inflammatory response syndrome and ARDS, and even multi-organ involvement. Next slide, please. Several mechanisms of myocardial injury has been postulated. If we go from the 12 o'clock position and go clockwise, you could see that you could have a direct viral cardiomyocyte toxicity because it can affect the cardiomyocyte, as we've just said. It can attach to H2 receptor and cause that. It can also cause a lot of microthrombi, and thromboembolism will lead to microvascular dysfunction and even myocardial infarctions. Vasculitis, endothelial dysfunction, even stress-induced cardiomyopathy. There are the cytokine storm or hyperinflammatory state will lead also to this myocardial injury. And in patients who may already have coronary artery disease, you could get plaque rupture causing a true myocardial infarction. Also bear in mind that the increased metabolic demands and hypoxia and hypotension all combine to create a demand-supply mismatch, oxygen demand-supply mismatch, which could also result in myocardial injury. Next slide, please. The combination of all these increased inflammatory response and decrease in cardiopulmonary function all combine to cause significant myocardial injury, including conduction system disease, leading to decompensated heart failure, acute coronary syndrome, myocarditis, hypotension, as we have seen in our cases, and tachyarrhythmias, bradyarrhythmias, drug-induced increase in QT interval, which could lead to polymorphic ventricular tachycardia or torsades de pointe, and sudden cardiac death. All these are possibilities from this myocardial injury. Next slide, please. So given this, we need to review some general principles in the management of these COVID-19 patients. There have been some recommendations from the American College of Cardiology and European Society of Cardiology and other professional societies on guiding the management. But here, I think first and foremost, it's important for every center to establish some protocols for effective clinical triage. Typically, in some hospitals, they have people in PPEs questioning and triaging patients right from the front of the hospital, asking screening questions. Anyone with fever, cough, shortness of breath, contact with a COVID-19 patient is separated right from beginning You want to do that quickly. You want to make a quick diagnosis and isolate potential patients with COVID-19, and then identify those with cardiovascular disease because they are at higher risk. You also want to individualize and limit your diagnostic testing to the essential tests that could facilitate management. This is not the time to do all kinds of tests. You want to do a quick clinical assessment to guide you. Consider using point of care testing to minimize transmission of this on healthcare workers, to prevent other healthcare workers from getting infected where possible. Universal precautions is essential, cannot be overemphasized. Personal protective equipment need to be worn by all healthcare workers in caring for these patients, and you should use masks even for the patients also. And wherever possible, telemedicine is a good way to go. We've been using it in our center, both for ambulatory care and even for those in the hospital. You can limit healthcare worker contact by creating telemedicine, even in the hospital, for things that you can derive via telemedicine. But in other times, you have to actually go in PPE. But if you use telemedicine, even within the hospital, you can limit and conserve your personal protective equipment so that only the few that actually need to be in the room go to the room and they stay in that room and take care of the patient until there's a change in shift. Next slide, please. For specific management of acute coronary syndrome, I just want to make a quick highlight that in these times, if the patient has clear risk factors for coronary artery disease and definitive clinical evidence to support or suggest acute coronary syndrome, consider fibrinolytic therapy if it's a STEMI, or manage medically for non-STEMI or stable angina. And in the high-risk group, if you have the capability, get CT, coronary angiogram, that will help you to define non-invasively the presence of obstructive coronary artery disease or otherwise. Next slide, please. This is a repetition or summary of what I've just said, a kind of triage algorithm to look at your ST elevation and decide whether to go straight to high-risk primary PCI or not. Of course, if you don't have PCI capability, medical management using fibrinolytics might be your best option. Next slide, please. Again, similar to the previous one, this is if you don't have a cath lab and you have a nearby cath lab that you can refer your patient to, consider, of course, you need to talk to the physicians over there and make sure that you are able to identify whether this patient needs to be isolated from beginning. And then those places that have cath lab need a dedicated cath lab for the COVID-19 patients. You don't want to be using the same cath lab for both COVID-19 positive and COVID-19 negative patients, even if it's potential. Next slide, please. Heart failure and cardiogenic shock, as seen in our second case, is another common presentation that healthcare workers need to look out for. A bedside clinical assessment is going to be key. Many times, because you can also have septic shock, you want to differentiate between septic shock and cardiogenic shock. And on the bedside, quick physical exam, cold, clammy extremities with hypotension and thready pulse, jugular venous distension, all will be supportive of cardiogenic shock rather than septic shock. And you could use point of care ultrasound if you have that, or 2D echocardiogram, even for just a limited view. You want to minimize the time of contact if possible. And if you confirm heart failure, guideline-directed medical therapy, including ACE inhibitors or angiotensin receptor blockers, are recommended. You know that the most recent studies have come out in support of angiotensin ACE inhibitors and ARBs. Initially, this was controversial, but now we know that it is safe and in fact might be beneficial. So if the patient goes into cardiogenic shock, consider the use of inotropic support and vasopressors preferably dobutamine by drip, or norepinephrine and vasopressin. Ideally, you want to give this through a central line where possible, but if you don't have a central line, put large bore IV lines like 18 gauge and above to administer these inotropic or vasopressors. Where you have the capability, here in the US, extracorporeal membrane oxygenation or even impeller is being used, but I know that in low resource settings, this may not be an option. So inotropic support might be your key to managing these patients. Next slide, please. Thromboembolism is another big issue in COVID-19. Next slide. As you will see, the risk factors for thromboembolism, obviously most of these patients come in with it. They have an acute illness, they have fever, they might be septic, they have heart failure, they have malignancies or COPDs. These patients are all at risk given that, and you get a massive inflammatory response with increase in C-reactive protein and interleukin-6. And elevation in D-dimer has been demonstrated to be another strong marker for poor prognosis. And in those patients with elevated D-dimer, more than 1.5, they are very high risk of having pulmonary embolism or a deep vein thrombosis and need to be anticoagulated, because all of that, if not taken care of, results in thromboembolism, myocardial infarction, and sometimes disseminated intravascular coagulation. So patients need to be prophylaxed for thromboembolism, and we are diagnosed. Sometimes you're not able to do a CT angiogram quickly. You could get an echo, EKG, and a clinical assessment to guide you. Start anticoagulation, preferably with low molecular weight heparin. Next slide, please. This slide is just to show you that the more critical or severe the illness at the top of the pyramid, the most severe cases have the worst thromboembolism. Therefore, the sicker your patient is, the higher their risk. Therefore, you should give priority in terms of treating or prophylaxing for thromboembolism in the very sick patients. Next slide, please. Emphasizing the same thing, most of the inflammatory markers are going to be high, including elevated D-dimer and high procalcitonin. You could confirm DVT, PE with ultrasound, venous ultrasound, if you have it. If otherwise, you can do a CTA and confirm PE. You should start anticoagulation as soon as you have that suspicion or you risk stratify the patient and start prophylaxis. Here, generally, most patients do get DVT prophylaxis on hospitalization. Next slide, please. Arrhythmias are another challenge to deal with in COVID-19 patients. And most of the proposed treatment like hydroxychloroquine and azithromycin, particularly when combined, are known to prolong the QT. And with prolonged QT, you are at high risk of developing torsades de pointe or polymorphic ventricular tachycardia. Therefore, you have to get baseline EKG and assess the acute corrected QT. If more than 500 milliseconds, you might want to hold off giving these medications, or if you must give it, ensure that you take countermeasures to reduce the risk and monitor them closely using EKGs and or telemetry, or even sometimes mobile phone with some of these apps. You can still check their QT even remotely. You can correct particularly potassium, magnesium, and calcium to minimize the risk. And you have to be cautious with diuretics, as this will further deplete your electrolytes when you give them. Tachycardia might actually be a good thing in that case because it's less likely, the patients are less likely to develop torsades in the presence of tachycardia. And of course, if the patient goes on to develop sustained ventricular tachycardia or ventricular fibrillation, obviously with hemodynamic instability, you need to do a DC cardioversion to correct and get them back to sinus rhythm. Next slide, please. So in summary, the manifestations of cardiovascular disease in COVID-19 can be diverse. The patients might present as angina, as unstable angina, as acute coronary syndrome, or even as heart failure, or mimicas of myocardial infarctions. So it's quite diverse. It's important to establish, rehearse, and follow your protocols. Have maybe dedicated ward and dedicated ICU, and where you have it capability, even dedicated cath lab for COVID-19 patients. Maintain consistent universal precautions, tailor your care to the individual needs of the patient, and avoid unnecessary testing. Wherever possible, point of care testing will help minimize healthcare worker exposure while optimizing your care for the patient. Adapt the care, of course, to the available resources in your center, and use telemedicine as much as possible. And that has been, very much upregulated here in the US. We're doing a lot of ambulatory care via telemedicine, and even within the hospital, telemedicine can facilitate your care while minimizing transmission to healthcare workers. Next slide, please. Thank you for listening. We're happy to take some questions at this time.
Thank you very much, Dr. Okafor, for that presentation. That was fantastic. We are going to transition to Q&A right now. Again, please, if you have any questions, type them into the chat box, and we will try to get to them. I would just like to introduce Dr. Mark Newton now, who's going to moderate the Q&A session. Dr. Mark Newton is a pediatric anesthesiologist and the Director of Global Health and Development for the Department of Anesthesiology at Vanderbilt University Medical Center in Nashville, Tennessee. Dr. Newton is also a consultant anesthesiologist at AIC Kijabe Hospital in Kijabe, Kenya. Mark, over to you.
Thank you, Monica. Thank you, Dr. Okafor and Sileshi. We want to open it up to questions. And so there have been a number of questions that have come in advance of the lecture, but also some lectures through the chat. So continue sending your questions. So I'll try to group these, and so we can learn during this time. But I would just encourage everyone on the lecture to continue sending in questions. And as the speakers answer these questions, if something comes up, just send us a message to the chat and we will watch those. So the first question I'd like to ask, and we're asking in advance, is the whole thing about ACE receptor cells. Can you go over a little bit about where these are located? I know you mentioned it in your lecture, but specifically talk about why potentially in hypertensive patients and diabetic patients, maybe there's a change in the baseline of ACE receptors, and just many patients in Africa are on ACE inhibitors. And what should we do in this scenario for those patients? So a little bit about the pathophysiology of the receptor cells and how they work, but also about the ACE inhibitors on a practical level. What should we do in Africa?
Thank you. That's a very good question. So S receptors, particularly S2 receptors, are known to be highly expressed on the alveolar cells, but also on the cardiac myocytes and on the GI. So they are in multiple organs, but highest density, of course, is in the lungs and the myocardium. And all the current studies, even before these studies came out, I know there was controversy as to the upregulation of S2, the implications for that for treating with ACE inhibitors or ARBs. But the most recent studies clearly confirm that it is safe. It is safe to treat your patients, either the hypertensives or those who had premorbid heart failure, to continue the treatment with ACE inhibitors and angiotensin receptor blockers. So you don't need to stop those medications. And in fact, the studies suggest that it might be beneficial, as we have known before. So do not stop your ACE inhibitors. You should continue them, and they are still recommended.
So Dr. Okafor, if someone comes in and they're not on ACE inhibitors, but we feel that would help with their cardiac failure, should we go ahead and start those, or should we start another drug that's used in our system?
Good question. If they are hemodynamically stable, if they are not hypotensive, it is reasonable to use ACE inhibitors and or ARBs, as the case might be. But of course, if these patients are having hypertension, you have to avoid ACE inhibitors at that point until they stabilize. These are very beneficial in patients with cardiomyopathy and heart failure. It's been demonstrated to improve survival in multiple prior studies. So we support the use of ACE inhibitors, and sometimes also beta blockers, but you don't want to initiate beta blockers when the patient is acutely volume overloaded. You want to initiate that when the patient gets euvolemic. So ACE inhibitors are recommended, except in hypotension or cardiogenic shock.
Okay, thank you.
Of course, where they may be allergic. Sometimes a lot of patients may be allergic to ACE inhibitors with cough, or they may have clear anaphylactic reactions, in which case you totally avoid that.
Mm-hmm. So based upon your experience in Nigeria, one of my concerns is, and people have voiced that, is that there's a lot of cardiac disease in general. And so now we're going to miss that cardiac disease that's at baseline pre-COVID. And now someone comes in with some symptoms and we think it's COVID. How should we just practically differentiate those?
If I understood your question well, if somebody had prior cardiac disease?
Yes, for example, we know that in Africa, there's patients that come in with cardiac disease, pre-COVID. I mean, these are people that it's just a normal. And so now they come in and we're all worked up about COVID, and we want to think it's COVID, but it's just their baseline illness that's in the country. And so how should we differentiate between treating them for COVID or just treating their baseline cardiac disease that's in the country?
Okay, so I think, as I've mentioned before, it's important to screen your patients, and often, even here, we pre-screen the patient even before they get to the hospital, or if they are at the hospital, they are screened right from the gate or from the lobby. Questions about fever, cough, shortness of breath, contact with anybody who may have tested positive or who is being treated for COVID-19. It's important to screen all comers because we know that you have asymptomatic transmitters who are walking around, not even having any symptoms. So screen your patient, even if they had cardiovascular disease at baseline. We know that they are at higher risk of getting the infection when they've had cardiovascular disease. Therefore, it is a good, reasonable thing to screen them. But at the same time, you should not avoid treating your patients. I've heard of cases of mishaps where, because somebody said they're short of breath, everybody flipped out saying it's COVID-19 and they didn't want to be infected. They left the patient. The patient may just be in heart failure, like you said, or having clear angina, which is still very treatable. And in any case, all the healthcare workers in the hospital should be wearing masks, should be having their PPEs to be able to screen these patients and triage them quickly. And if there is good reason to suspect COVID, at least isolate them until you rule them out for COVID-19. That's part of what we do here. If we have reason to suspect there's a combination of premorbid cardiovascular disease and COVID-19, you isolate the patient in a respiratory room and continue your treatment and send for the test. And usually you get back the test within 24 to 48 hours, and you're able to say, okay, patient is COVID negative. You continue your regular treatment. If patient is COVID positive, of course, you get infectious disease involved, and you initiate appropriate therapy as indicated.
Okay, thank you. Thank you very much. So the second subject is the whole idea of troponins and measurements for cardiac disease. What do we do if we're not able to measure those? And can we still treat COVID-19 patients with cardiac disease without that lab? And are there any substitutes that we can use to follow when we don't have that lab available to us? And maybe you can explain why we would measure that just at baseline. What is that?
Actually, some authorities are not encouraging you to just routinely check troponin except it's indicated, because as has been observed in most of the literature, 20 to 30% of the patients are going to have elevated troponin. And elevated troponin is just a marker of myocardial injury. So which we've said is relatively common in this condition. And one problem with checking troponin is that everybody gets carried away once the troponin is positive. Oh, it's an MI, and they have something else to deal with. But the reality is that, especially in stress or sepsis or any kind of significant critical illness, troponin can be elevated. And if troponin elevation, as we saw in some of my earlier slides, does not necessarily mean acute myocardial infarction. So this could just be demand, which means the patient is hypoxic or anemic or hypotensive. So if you correct the underlying problem, like hypoxia or hypotension, that stress on the heart will be eliminated. If in a few cases it's true plaque rupture, so you want to say, does the patient have angina along with the troponin, or even before you check troponin, is this patient having typical angina symptoms? Are there EKG evidence like ST elevation or ST depression to suggest ischemia? If none of those, if you don't have clinical and maybe EKG evidence to suggest acute coronary syndrome, it may not necessarily be a good idea to be checking troponin just as a prognostic marker. We know that the higher the troponin, the worse the outcome. But you can use D-dimer for that, okay? So D-dimer, it's a strong prognostic marker. So, and it can tell you also about thromboembolism. So except your patient is having clinical features to make you concerned about acute coronary syndrome, you don't have to worry that you don't have troponin available in your center. You could do creatine kinase, but most of that is going to be elevated because of the muscles, muscle breakdown. That's not been the typical thing. Troponin is more sensitive, okay?
Okay, great. And you mentioned also checking DNP. Can you describe what you're looking for? Whether we have it or not, we can discuss that, but what is that?
Okay, B-natriuretic peptide is secreted by the heart, the ventricles in times of stress, either high pressure or high volume. Anything that stretches the myocardium or stretches the ventricular chambers will cause an elevation in B-natriuretic peptide. And that's what you measure. Some people measure pro-BNP, which is the preformed BNP, and you can use that, or you can use the BNP. So the more elevated typically this is, the more likely that the patient has heart failure. But again, as said, if you have high intraventricular pressures, as in PE or even severe hypertensive crisis, the BNP can get elevated. So you don't want to check that routinely, except you suspecting the patient has heart failure or decompensated heart failure or severe cardiomyopathy. That would be another biomarker telling you how serious their heart failure might be. That's why you check it.
Okay, great. So the fourth kind of topic that people had questions regarding was the whole idea of this thromboembolism and the effect that it has on the body. So the questions are, have we seen an increased incidence of pulmonary hypertension in these patients, and that sildenafil is available in some countries in Africa? Should we routinely use this if we do not have transthoracic echo or TEE or anything like that, just from clinical signs? And then, so let's maybe answer that one, then I'll ask some other questions about the whole idea about thromboembolic events.
Okay, thank you. First of all, if you suspect thromboembolism, I mean, you could do from clinical evaluation, is the patient getting more short of breath, more hypoxic? Is there maybe hypotension if they have like PE? You could also use EKG if there is tachycardia or evidence of right-sided strain, like right axis deviation in the presence of tachycardia. That might suggest PE. You could get a non-invasive study like a quick look 2D echocardiogram. If you see evidence of right ventricular strain, that might also suggest a PE. Now, because this is an acute event, you might not necessarily have pulmonary hypertension right away. And if you have it, it might be transient. So the appropriate treatment will be anticoagulation more than trying to reduce the pressure, because the primary problem is the thromboembolism. So if you can correct that with anticoagulation, you might be able to relieve the consequences of that with transient elevation in the pulmonary pressures. So I would not recommend initiating sildenafil on every patient because of that, because you're not really treating the main problem. The thromboembolism is the main issue there, and anticoagulation would be a preferred treatment to alleviate that. Okay.
And so you mentioned in your talk about placing patients that are inpatients on anticoagulants and low molecular weight heparin. What if we do not have that? All we have is heparin. And is there any kind of protocol that we can use for an inpatient, for everyone that comes in that's sick enough that's requiring oxygen for anticoagulation?
Yeah, absolutely. If you don't have low molecular weight heparin and you have unfractionated heparin, that's a good option. Unfractionated heparin, can be used for prophylaxis. Actually, just given subcutaneously, you can give unfractionated heparin for DVT prophylaxis. And if you do have thromboembolism that is confirmed, you might need to put them on the drip and titrate your PTT to between 40 to 60 to keep them adequately anticoagulated and treat your thromboembolism. So yes, absolutely. If you need to, you can use unfractionated heparin. And if you don't have that, you can use SCDs, which are commonly used in post-op patients, pneumatic compression devices to help prevent deep vein thrombosis. So all those options are acceptable. The thing is, one of the challenges, of course, with unfractionated heparin is that you require more intensive monitoring and more staff resources. Somebody has to check the PTT, make sure the patient is adequately anticoagulated and not excessively or overly anticoagulated where you can cause bleeding. So you need to titrate more often and you need to monitor it. Whereas low molecular weight heparin allows you to give, one dose maybe twice a day and reduce staff use and resources with that. So that's why maybe nurses and healthcare workers would prefer low molecular weight heparin where available, but unfractionated heparin is definitely an alternative.
Okay.
If I can, Mark, if I can just add to that,
yes.
I think prevention would go a long way. So any patient that is admitted in the hospital, being very aggressive with making sure that they're mobile. If they are able to walk, even with the oxygen and the nasal cannula, make sure that they walk. And if they're bedridden, even doing passive, leg motions. If you don't have compression devices, even manually compressing the legs to reduce stasis can be helpful in preventing clot formation.
Okay. So are you saying, Dr. Sileshi, that someone who's really ill in the hospital, we should be getting them out of bed and walking them around?
Absolutely. If they have the ability to do so, we should definitely push to have them be mobile, because it will significantly reduce your likelihood of clot formation.
Okay, thank you. Yes, from my many years in Africa, that's one thing that has changed over the years, is that we tend to have patients sitting, not out of bed. In the past, more patients were getting out of bed, so we need to encourage our nurses and the people on the wards to get patients out of the bed and have them move. Somebody asked about aspirin, and is there a role in aspirin, low dose aspirin, either as an inpatient or as an outpatient to prevent any thromboembolic event, since we do use that at times for cardiac patients?
Yes. Well, aspirin is an antiplatelet agent, and it is useful, but it's not proven to prevent other thromboembolism. I've not seen that data, so using it alone may not be as effective in preventing thromboembolism. Of course, if somebody is ambulatory and able to move around, I think that's one good way of preventing thromboembolism. If someone is in the hospital and you have reasons to suspect, or maybe they have high risk for acute coronary syndrome, or they already have coronary artery disease and we're on aspirin prior to hospitalization, it's a good thing to continue the aspirin because that reduces their risk of acute coronary syndrome. So that would be a case where I use it, but using it for prophylaxis, for DVT, is not proven, therapy.
Okay. Not helpful. Okay, so another question was about inotropic support. And I know on your slide it had mentioned the use of dobutamine and norepi and vasopressin, things like that. Now, what about if we do not have those? What is the main drugs at our government hospital? We only have adrenaline, and every once in a while we can get dopamine. So what would you suggest that we do in that situation? And also, as you're commenting, the role of calcium and checking calcium in these types of patients.
I see. Van, do you want to speak to that?
Sure. Yes, I think epinephrine or adrenaline is an excellent choice in patients who have cardiogenic shock. So obviously titrating it to the correct dose would be helpful. And if you have the ability to, infusions that and able to control the dose, then you can really titrate it to help with inotropy, as well as it serves as a vasopressor. But if you don't have a way to control the dose, you can even put epinephrine in a 1 liter saline bag and change your flow meters and titrate it to effect that way. If you have dopamine and you don't have adrenaline, dopamine can also be used, but it's important to be mindful that dopamine, in addition to affecting your cardiac function, it could affect blood flow to the renals and so forth. And its dopamine's effect really changes based on the amount of drug that you're giving. So if I had a choice between epinephrine and dopamine, I personally would choose epinephrine. It's a little bit more cleaner drug and really works specifically on inotropy and increasing vasopressor without affecting other organ systems.
And then, Bon, any comments about calcium and inotropes and,
Yeah.
Sure. Calcium is a great inotrope. You want to make sure that you have adequate calcium level, but it's important for you to differentiate between cardiogenic shock and inadequate supply to the heart versus septic shock, which is leading to cardiogenic shock. So if your problem is solely isolated to your heart, I'll be less inclined to use calcium.
Okay.
But if it's more, a combination of sepsis and cardiogenic shock, I'll be more inclined to use calcium and epinephrine and so forth.
Great.
Henry, do you want to add?
Yeah, let me just mention that, and thank you for that contribution, Dr. Sileshi. I think that if you are, whatever agent you have available in your center, you should titrate to mean arterial pressure of 60 to 65. That will kind of guide you. A mean arterial pressure of 60 to 65 allows adequate perfusion, so you don't need to give too much of any of these vasopressors or inotropic agent, because they all have their own adverse effect, that will further cause an increased demand on the heart and accelerate myocardial injury. So that's something to pay attention to. Generally speaking, they are preferred, like the dobutamine might be preferred, but where you don't have the preferred inotropic agent, definitely go ahead with dopamine if that's what you have available, or adrenaline, but titrate it. Don't need to give excessive doses. Titrate it to just achieve mean arterial pressure of 60 to 65, and back up so you don't get the downside too much. Okay.
Yeah.
Well, Mike,
thank you.
If I can add one more thing, there were additional questions that were associated with vasopressor use and central line versus giving those in a peripheral line. Yes, you can give inotropic agents through peripheral IVs. Try to get as large bore as an IV as you can, 18 gauge and above, and try to put it on a larger vessel, if possible, close to the antecubital fossa or something larger. But yes, you can give vasopressor agents peripherally as long as you monitor it carefully.
Great. Well, we need to start wrapping this up. So thank you both. It was a great lecture, and the Q&A session was active, and we learned a lot on the discussion. So we just want Dr. Sileshi and Dr. Okafor to kind of give us 30 seconds or a minute to wrap it up, and then we'll turn it over to Monica to finish up. I would just encourage everyone to join the WhatsApp group. There's many questions that we're going to have over the next week. So we do have a WhatsApp group, and it's multidisciplinary. So we have pulmonologists, cardiologists, ID, anesthesia, critical care. We can all try to respond. And so I would just encourage you to sign up for that WhatsApp group. So Bon, why don't you go first, and then Dr. Okafor, and then we'll turn it over to Monica.
Sure. Thank you again for this opportunity. Thank you for coming to listen to the talk. If I can just highlight for me, what would be the key takeaway points. One, know that COVID-19 infection by itself, independent of whether a patient has a previous cardiovascular disease or not, can affect your cardiac function. And patients can have cardiovascular disease solely from the COVID-19 infection. So as you're caring for this patient, if you start with a high suspicion and look for signs of myocardial injury, you'll be better. You might be better to, you'll be able to better serve your patients. The second point that I want to make is, thromboembolic disease is a big deal and has been associated with this infection. So whenever possible, use prophylactic anticoagulation in addition to encouraging ambulation to avoid complications of that. Those are the kind of main takeaway points for me.
Thank you, Bon. Dr. Okafor.
Thank you all for coming, and thank you to Assist and Echo, and thank you, Dr. Sileshi, for your contributions. I appreciate that. As we've said, COVID-19 comes with multi-organ damage, particularly cardiac disease. Other de novo cardiac disease or pre-existing cardiac disease is made worse, and patients with cardiovascular disease are at higher risk of poorer outcomes in this condition. So it's important to initiate early preventive strategies. You cannot overemphasize the need for prevention, DVT prophylaxis, and a quick care. But also at the same time, you need to stay safe. You need to use your PPEs and universal masking, both for the healthcare worker and for the patient, and do quick screening and point of care ultrasound could be quite helpful in helping you decide between septic versus cardiogenic effect in addition to your clinical assessment. Those are things that will minimize the chances of transmission while optimizing the care for the patients. I know we're over time, but I appreciate your listening. I think we'll continue this on the WhatsApp forum if you sign in. Thank you for your time.
Thank you so much. Thank you, Dr. Bond, Dr. Okafor, and Dr. Newton for that really interesting presentation. Thank you to Vanderbilt Institute for Global Health, GE Foundation, Project ECHO, and others for helping to put this together. I know we're over time, but two very quick last things for everyone. I'm going to pass it along to my colleague Claire to share the information on the WhatsApp group. And then we will be sharing a short poll. And if you could please fill that out before we close today, that would be great. Thank you very much.
Hi, so as was mentioned, we have a WhatsApp group for the series. We would love for you all to join, and you may use this WhatsApp group to continue asking questions or share what's happening with COVID in your area. You can scan this QR code that you see on the screen. We'll also be sending out a link to the group through your email if we have your email address. And if you have any other questions or if you want to get on our email list, you can email us at echo@assistinternational.org. Thanks.
Hi, everyone still on the call. Thank you again for joining. Thank you again to VIGH, Vanderbilt University Medical Center, Vanderbilt Institute for Global Health, and GE Foundation for making this possible. We're going to leave the poll open for a few more minutes, so please fill it out if you can. And we look forward to seeing everyone on next session. The next session will be next Wednesday. Thanks everyone again for joining. We're going to close the session now. We hope to see you all again next week. Thank you.
Thank you. Bye.
Thank
Thank
you.
you. Goodbye, everyone.